Okay guys, very good morning. Just 1 minute. Very good morning guys, just 1 minute. I think we are loud and clear. So we are back. We are back with the topic. I think we are previously discussing about something regarding partial pressure. Partial pressure and gas exchange. So we are about to discuss about this partial pressure and gas exchange. So how these partial pressures and gas exchange are maintained? See, this is very important. So this is alveoli. So there is inhaled air and there is exhaled air, right? So this is inhaled air and this is exhaled air. Okay, now exhaled air consists CO2, inhaled air consists oxygen. Okay, now this is alveolus, right? This is alveolus. Now the partial pressure of oxygen is 100 mm Hg here in the inhaled air, right? So it comes in the alveoli. The partial pressure of oxygen is 104 and the partial pressure of carbon dioxide is 40. Okay. So this is capillary. This is capillary. Now I will just represent with colors. This is venous end. This is venous end. Remember, blue color, and this is arterial end. Remember, red color. Okay. This is arterial end. Okay. Now, in the oxygenated blood, in the arterial capillary, the oxygenated blood, the partial pressure of oxygen is 100 mm Hg. Okay, and the partial pressure of carbon dioxide is 40. Right. So the partial pressure of PaO2 is 95 to 98 mm Hg. Okay, and PaCO2 is 40 mm Hg. So when the blood flow like this, what happens is the oxygen enters. Oxygen gets entered into this component, and the carbon dioxide gets absorbed. See, oxygen flow into capillary and carbon dioxide goes to where? To the alveolus. From alveolus it is exhaled. So oxygen is inhaled, oxygen is absorbed, gets into the arteriole, and carbon dioxide is absorbed from venous capillary to alveoli, and it is exhaled to outside. So in case of venous capillary, I will represent it with blue color. In case of venous capillary, venous blood, the partial pressure of oxygen will be 40. Obviously there will be low partial pressure of oxygen, and the partial pressure of carbon dioxide will be 46. PaCO2 is 46 mm Hg, right? mm Hg. Okay, the partial pressure of oxygen is 40 and partial pressure of CO2 is 46, right? So this is capillary, venous and capillary, and arterial and capillary. Now you understand, right? Now you understand. So the oxygen is inhaled. Now the inhaled oxygen comes here, which has a partial pressure of 104. It gets absorbed into the venous and capillary, and it flows towards the body. Now the blood which is coming towards here, the carbon dioxide is absorbed, gets into the alveolus, and it's exhaled to outside. So the venous blood consists of partial pressure of the oxygen with 40 and the partial pressure of carbon dioxide in the venous blood is 46 mmHg. Remember this. Okay. Now you might get a question like, sir, if you say like, how does the surface of so-called alveolus exchange with the blood stream or the blood capillary? Oxygen, exchange oxygen with blood capillary, right? So just wait a minute. So we'll draw something here. So can you tell me what is this one? What is this one? It is the endothelial lining of capillary. This is the endothelial lining of capillary. Remember, this is the endothelial lining of capillary, and this one is the interstitium. This one is the interstitium, right? See, this one is the interstitium, right? Now this one is the alveolar epithelium, right? This one is the alveolar epithelium. This one is the alveolar epithelium. Now this one is the, what is this one? Can anyone tell? It is the epithelial basement membrane. Basement membrane. So what this one is, this, wait, I will draw with yellow color. What might be this? I'll draw it with even broader nib. So what is this yellow one? This is nothing but surfactant layer. Surfactant layer. Now we already said like this is the endothelium, that is, I mean surface epithelium of alveoli. This is the epithelium of alveoli. These are cells. These are nothing but cells, right? So this is the alveolar epithelium, and this is its basement membrane. Means the alveolar epithelial cells basement membrane. This blue, wait, I will show it laser. Now this is the basement membrane. This is the alveolar epithelium. See the cells, the epithelial cells, and this yellow color is the surfactant layer, which is residing on the walls of alveoli. That is fluid and surfactant layer. Now here the RBC will be there. Here the RBC will be there. Now what happens here? What happens here? Simple is the oxygen gets into RBC. The oxygen gets into RBC. Okay, and the carbon dioxide gets into alveoli. Carbon dioxide gets into alveoli. You see this? Now how this occurs? How this occurs? This occurs by a simple mechanism, that is diffusion. This occurs by diffusion. Okay, so the oxygen gets transported to RBC, and the carbon dioxide gets transported from RBC to alveoli. Now my question is, exchange of gases through cell membrane, that is phosphobilipid layer, occurs due to how due to which property? Which property? Lipid solubility. Previously we already studied, right? In that lipid solubility, what is the example that we given, which are lipid soluble and which can easily permeable through cell membrane? Gases is the example that we given there. Which gases? Oxygen, carbon dioxide, as well another one is alcohol. Now you can understand what is the importance of physiology. See, you know the basic, you can explain anything easily. Now we also discussed about interstitial fluid. Interstitial fluid is important for transportation of compounds or substances from tissue to blood capillary. This is blood capillary and this is the endothelium. See, I'll show. This is endothelium. This is endothelium and this is all blood capillary, and this is blood corpuscle, that is RBC, and this is the tissue. What is the tissue? Surface, that is that alveolar tissue. See here cells. These are the cells, that is with nucleus, and see the gas is transported from alveolar tissue to interstitium. This is interstitial. See, this is interstitial fluid. The interstitium and towards the blood capillary. In that capillary it enters the RBC, and with which feature is utilized here for the penetration of oxygen and carbon dioxide, that is lipid solubility of the cell membrane. See, now the complete topic I think you got in front of your eyes, right? Okay, now I will tell you one thing. The gas exchange by simple diffusion given by Fick's law, very important. Fick's law. Now what is that Fick's law? The Fick's law states that the rate of diffusion is depends on, or you can also say that it depends on the membrane. You call it which property of membrane? The membrane thickness, as well the partial pressure of the gas and the gas itself, whether it is oxygen, whether it is carbon dioxide, or whether it is any other gas. So the rate, what is Fick's law? The rate of diffusion depends on membrane, partial pressure, and the gas which is being diffused. Okay, that is Fick's law. Okay, now coming to the next thing, what we will discuss? We will discuss what are the factors of the Fick's law that define them. So we will write here Fick's law. What are those three factors? First one is gas. Now why gas? Why not others? Gas, right? If the gas has small size particles, then the diffusion occurs very rapidly and to a larger extent, and the gas should have good lipid solubility characteristic. Then it can easily penetrate the cell membrane. And regarding lipid solubility, one statement you should remember: carbon dioxide is 15 times faster than oxygen lipid solubility, right? Carbon dioxide is faster than oxygen, not 15 times, sorry, 20 times is faster than oxygen. How many times? 20 times. Carbon dioxide is 20 times faster than oxygen regarding lipid solubility. So carbon dioxide has more lipid solubility nature. Now coming to the second feature, that is partial pressure. So the more the partial pressure, more diffusion occurs. Example, if you have ever seen an oxygen therapy, that means giving oxygen to the patient through mask, then there will be more partial pressure of oxygen in the patient's body. That leads to increase in oxygen supply. So that implies there will be an increase in partial pressure of oxygen. You get it? By this way you can simply correct the hypoxia of the patient. You got it? Now the third feature is respiratory membrane. Regarding respiratory membrane, the area of the membrane, right, it should be normal, something like 70 meter square for better diffusion of gases. And also the thickness, the less the thickness, the more the diffusion occurs. Normal is 0.5 micrometers, right? So lesser area, see, so I want to tell one thing, right? Micrometers, I'll just drag it here. Now if there is more area and less thickness, then more diffusion occurs. More diffusion occurs. But if there is less area and more thickness, then less diffusion occurs. Less diffusion occurs. Right? Now, this is the condition where the area will be decreased and the thickness increased. That condition is called membrane diffusion disorder. Membrane diffusion disorder, which is most observatively can be seen in interstitial lung disease or ARDS, acute respiratory distress syndrome, or pneumonia. And the best investigation for this condition is DLCO, right? DLCO. What is DLCO? Diffusion capacity in lungs for carbon monoxide. What is DLCO? Diffusion capacity in lungs for carbon monoxide, right? So the best investigation for membrane diffusion disorders is DLCO. Okay. Now we'll come to carbon dioxide transport. Carbon dioxide transport. So regarding carbon dioxide transport, there is the condition of 4 milliliters per cent or 200 ml per minute of transport occurs. 200 ml per minute of carbon dioxide transport occurs. Okay, now just 1 minute, brothers. So the first one is different forms of carbon dioxide that we see are dissolved carbon dioxide in the form of bicarbonate, and trust me, this bicarbonate is the main or most common form by which the carbon dioxide transport occurs. It's something like 75%, and the other form is carbaminohemoglobin, right? That is something carbon dioxide hemoglobin is. Now, how does oxygen transport occurs? How does oxygen transport occurs? The rate of transport of oxygen is 200 ml per minute or 5 ml percentage. So rate of oxygen transport is more than the carbon dioxide. Now oxygen is transported in two forms. One is hemoglobin bound, that is nearly 99% takes place like this. Of course it takes place like this. What does the blood do? It is the obvious function of blood. So 99% of the oxygen is transported in hemoglobin bound oxygen form, and one more form is dissolved oxygen. See, this is very rare. Only 1% of the oxygen is transported in this way, in the form of dissolved oxygen, but most of the oxygen is transported in the form of hemoglobin bound. So what are some norms? One hemoglobin molecule bind 4 oxygen molecules, right? Now 1 gram of hemoglobin carry 1.33 ml of oxygen. Okay. Now normal hemoglobin is generally 12 to 16 gram percentage. Now this will carry how much? 12 into 1.33, that is 18 to 19 milliliter percentage oxygen is carried by a normal hemoglobin containing person. Now dissolved oxygen is something like 0.3 ml percent, and partial pressure of oxygen depends only on dissolved oxygen. That is called Henry law. What is Henry law? What is Henry law? Partial pressure of dissolved oxygen. Partial pressure of oxygen in a body, in a human body, depends only on dissolved oxygen. This is called Henry law. Very important. You just remember. I will tick it with a yellow color. Henry law. Okay. Now the very most important concept, that is oxygen hemoglobin dissociation curve. I think most of the doctors are waiting for this concept. Most probably today we will be completing respiration and we will complete respiration. We will stop most probably. The time's up. Tomorrow I will finish rest of the physiology. Tomorrow you have neuro, special senses, all this thing, high altitude physiology. Yeah. Tomorrow we will finish rest of the things. And after physio I will be starting PSM, preventive social medicine. Okay. So get ready with that topic. Okay. So wait. Okay. So see, some of the doctors are asking, sir, please keep a webcam, so that we can visualize you also. Watching only the class is something boring. Like we are interested to watch even your explanation directly also, sir. See, I'm not against it, but first of all, let us finish all these sessions. Surely I will make videos with my video itself. Okay, so no problem. So we'll start with oxygen hemoglobin distribution curve. Very important. The OHB curve is of sigmoid shape. Sigmoid shape. Why? Due to relative affinity, due to a feature called relative affinity. It's not a pure affinity, it's a relative affinity, or you can also call it like cooperative binding, something like cooperative binding. Now what is meant by relative affinity? So there is a increase in affinity towards the oxygen, or increased oxygen affinity with each oxygen molecule binding. So there is a gradual increase in the affinity towards the oxygen with each oxygen molecule binding. That is called relative affinity, due to which the oxygen hemoglobin dissociation curve gets a sigmoidal shape. Now there is a shortcut that we most commonly define it as RRR. That means right shift. Remember, right shift when during release of oxygen into tissue. Right shift regarding release of oxygen into tissue, called as Bohr's effect. Called as called as Bohr's effect. Bohr's effect. a right shift with the release of oxygen into tissue called as Bohr's effect. Now, high partial pressure of carbon dioxide in tissues cause loading of carbon dioxide and unloading of oxygen from hemoglobin Now, if there is a high concentration of carbon dioxide in the tissues, it causes loading of carbon dioxide and unloading of, that means separation of oxygen. Means if there is high concentration of carbon dioxide in the tissue, then it causes separation of oxygen from the hemoglobin. For example, you see the blood is coming like this to a muscle. Say something like this is muscle tissue. Now in this muscle the oxygen depleted and the carbon dioxide is high because the oxygen already depleted. We utilized the oxygen. Now it is in a hypoxia state. The carbon dioxide got deposited. Now when the blood is coming in this way, as the blood is rich in oxygen, right? As the blood is rich in oxygen and it is deficit of carbon dioxide, the carbon dioxide is collected from here, right? And the oxygen is separated from the hemoglobin and it is supplied to the tissue. Now what I want to tell is, in a tissue, if there is a high concentration of carbon dioxide, then it can cause loading of carbon dioxide. Loading of carbon dioxide means the carbon dioxide goes and bind to the hemoglobin in the blood which is flowing near to the tissue, and the oxygen which is already in a bind form with the hemoglobin gets separated and it gets transported to tissue itself. By this way the oxygen and carbon dioxide transfer occurs. And one more thing is LLL, left shift of curve occurs when hemoglobin bind to oxygen in lungs. That is called Haldane effect. Very, very important. Haldane effect. Haldane effect. Why this happens? Due to high oxygen affinity. High oxygen affinity. Right? So the left shift occurs when the hemoglobin binds to oxygen in the lungs. Right? So that is called as Haldane effect. Right? So if you take placenta is something special where we see double Bohr's effect and Haldane effect. Double Bohr and Haldane effect is seen in placenta. I will just erase this. Wait. Double Bohr and Haldane effect is seen in placenta. So you got it, right? You got it? You got it or not? Okay. Now we will just draw the graph and we will disperse something from it, right? Now the graph is a sigmoid graph. So there will be a right shift and there will be a left shift. Now right shift occurs. Right shift means decrease affinity for oxygen. Decrease affinity for oxygen. Okay, so it occurs when there is increased concentration of carbon dioxide, when there is increased proton concentration, as well as there is decreased pH, power of hydrogen, and when there is increased 2,3 bisphosphoglycerate, 2,3 BPG, sorry, 2,3 DPG, sorry, 2,3 DPG, 2,3 DPG, and when there is increased temperature. Now everything gets reversed in case of left shift. Left shift means there is increased affinity for oxygen. Increased affinity for oxygen means in which conditions you see opposite of right shift. That means decreased concentration of decreased concentration of carbon dioxide, decreased proton activity, increased pH, decreased 2,3 DPG, and decreased temperature. And also one more thing that you should remember, where the left shift of oxygen hemoglobin dissociation curve is seen, that is HbF, fetal hemoglobin shows left shift of oxygen dissociation curve. Okay or not? Okay or not? And one more important thing, here I will write methemoglobinemia shows left shift, okay, and carboxyhemoglobin shows left shift, okay, left shift. And fetal hemoglobin, obviously we have discussed, HbF shows left shift. In case of right shift, some extra points are sulfhemoglobin shows right shift, and sickle cell, sorry, what is that? HBSS, it shows right shift. Right? Everyone okay? Now what happens in 2,3 BPG? The 2,3 BPG, the bisphosphoglycerate 2,3 BPG, what happens is it binds to beta chain of HbA and cause oxygen release. This 2,3 BPG, I will write it here. The 2,3 BPG, it binds to the chain of beta chain of HbA, adult hemoglobin, and causes oxygen release. Now in case of fetal hemoglobin, what happens? Fetal hemoglobin, the 2-alpha 2-gamma globulin chain, which contains 2-alpha 2-gamma globulin chain, but there is no beta chain, there is absence of beta chain, so there is no 2,3 BPG binding. So the HbF affinity has higher oxygen affinity, hence it extracts oxygen from maternal hemoglobin, that is adult hemoglobin. Whereas in case of carbon monoxide poisoning, carbon monoxide has 210 times more affinity for hemoglobin than oxygen, more affinity for hemoglobin than oxygen, right? So it forms carboxyhemoglobin, that is COHB, and it appears like cherry red fire in a closed room, right? Now this won't release the oxygen, right? It won't release the oxygen, so death occurs by, in case of carbon monoxide poisoning, death occurs by hypoxia, because it won't release the oxygen, so death occurs by hypoxia in case of carbon monoxide poisoning. Okay, so that is, I think we have some things that we should discuss here. Now enough of all this process, we will discuss the main component of today's class, the pacemakers of respiration. Where are the pacemakers of respiration situated, right? It is situated in medulla, which is called as pre-Bötzinger complex, or PBC shortcut, pre-Bötzinger, not BBC, PBC, pre-Bötzinger complex. What it does is, it stimulates the respiratory muscle and produce something called automatic involuntary breathing. Automatic involuntary breathing. Now there are some respiratory groups, some group of tracts that you should remember, the dorsal respiratory groups, which acts on inspiratory muscle. Just remember this, very important INCT questions these are, as well as for NEET PG also. Inspiratory groups or inspiratory group of muscles, and ventral respiratory groups, they act on Bötzinger complex. Bötzinger complex for what? Sorry, ventral respiratory groups, they cause forceful respiration. They cause forceful respiration, forceful expiration. Example, in which conditions they are activated? In coughing, right? And also sometimes in exercise. So ventral groups or ventral respiratory groups, they cause forceful expiration in case of coughing or exercise. Now pre-Bötzinger complex, they gives ramp signals, the fast steady signals to dorsal respiratory group. This is very important statement. INCT 2020. INCT, I think May session paper we got this question. So just remember this. Now one more important thing is apneistic center. Most of the doctors have asked me, sir, please explain apneistic center. Why you want to know much about apneistic center? Okay, so what it does is, it activate DRG, it activate dorsal respiratory group. That is its simple function, and also the main function, it increases the depth of respiration. So the depth of respiration is defined by apneistic center. It increases the depth of respiration. Then what about pneumotaxic center? It inhibits apneistic center, and what it does is, it prevent apneasis, it prevent excess depth in the respiration, prevent apneasis. And what it does is, it simply increases the rate of respiration, as simple as that. Now if there is a medulla lesion, so these are important, you will get a clinical question. If there is a medulla lesion, what will happen? Respiration stops, which is called as apnea occurs if there is a medulla lesion. If there is a pons lesion, if there is a lesion in pons, what happens to the respiration? There will be irregular irregular and shallow breathing is observed. There will be irregular and shallow breathing is observed. If there are mid-pontine lesions, and if you also undergo with bilateral vagotomy, then no explanation here, just you can simply understand that apneusis occur. Nothing much, simply you can get the logic, apneusis occur, that's it. No more explanation needed at all. Respiration simply stop in inspiration only. The respiration activity simply halted in inspiration content only, or inspiration phase only. So you will be in a apneustic state. That means you will be in a deep or increased depth of respiration is observed. You will be in a apneustic state. Now, how does the respiration regulation occurs? The regulation of respiration, how it's done, right? So it is actually done by chemoreceptors. Right? So what they do is they simply sense and they correct the hypoxia. And also they correct the hypercapnia. That means if there is any increased concentrations of carbon dioxide, which is defined as hypercapnia, they correct it by stimulating the respiratory centers in brainstem. Okay, the respiratory centers present in brainstem. Okay, so in that process, the chemoreceptors, they correct all the hypoxia or hypercapnia conditions. So what happens is this results in hyperventilation. That means there will be an increase in tidal volume, increase in respiratory rate, and also there is an increase in partial pressure of oxygen and decrease in partial pressure of CO2 to normal only. See, hyperventilation doesn't mean that oxygen levels simply spike up. No, that is not the condition. Hyperventilation means the so-called values which have actually decreased due to some problem, they will be established to their normal state by hyperventilation. That's it. It will not go beyond the normal level. Okay. Now what are these chemoreceptors? So there are two groups, that is central chemoreceptor. This pen is not writing here. Wait. So there are two groups. One is central chemoreceptors, okay, and peripheral chemoreceptors. Okay, central chemoreceptors and peripheral chemoreceptors. Now central chemoreceptors located in ventral medulla, and they are only stimulated if there is increase in proton concentration in CSF. Okay, there is an increase in proton concentration in CSF. And peripheral chemoreceptors are situated in carotid bodies at bifurcation of common carotid artery, right? And it's also seen in ninth sorry, it's not seen in ninth now, supplied by ninth now, right? Okay. And another place where we observe these things are aortic bodies at arch of aorta, supplied by 10th. Okay. Now the peripheral chemoreceptors, they are actually stimulated by, remember this, stimulated by all sort of changes, something like there is increase in PaCO2 or decrease in PaO2 or increase in proton in blood. So when these conditions prevail, the peripheral chemoreceptors, they get stimulated. Now, what does this peripheral chemoreceptors contain? They contain oxygen sensitive potassium channels in glomus cells. In glomus cells, which are actually type 1. Remember this, the peripheral chemoreceptors, they are actually contain oxygen sensitive potassium channels in glomus cells, which are actually a type 1 type. Remember, peripheral chemoreceptors are not stimulated. See, this one also you remember, they are actually not stimulated by anemic hypoxia. Why? Because sometimes you will be given a clinical scenario and you will be asked which sort of chemoreceptors will be initiated. So it will not be stimulated by anemic hypoxia, but rest of all other types of hypoxia can stimulate peripheral chemoreceptors. Now, one more thing you have to remember is regarding the blood-brain barrier, the carbon dioxide which is present, it can cross the blood-brain barrier and it can stimulate both peripheral chemoreceptors as well as central chemoreceptors by making proton in the CSF, by increasing the proton concentration in the CSF. So it is the main stimulus. So this mechanism is the main stimulus. Now you understand how these chemoreceptors, they get activated when carbon dioxide increased. Our body automatically adjusts to normal state. How? By this mechanism. This carbon dioxide, if it gets increased in the human body, it just simply crosses the blood-brain barrier and it simply initiates or activates the peripheral chemoreceptors and central chemoreceptors. How? Because the carbon dioxide which is increased in the body, it also increases proton concentration in the CSF. This leads to activation of peripheral chemoreceptors and central chemoreceptors. So this is the main stimulus. What is the main stimulus? The main stimulus is hypercapnia. Hypercapnia is the main stimulus, which is the actual drive for the respiratory regulation. Respiratory regulation. So with this we end the respiratory system. Finished. Okay, you check everything. Okay, everything. Okay. With this we finished the respiratory system, and I am keeping a big namaskar to all for today's class. Okay, I'll keep a big namaskar. Tomorrow we will come with a even more better topic, that is cardiovascular system, and it is my word, I will complete the so-called physiology tomorrow, and next we will start PSM. The next subject is PSM. Okay, we start PSM. So till then, tata, bye bye, good evening, and your wise doctor. Thank you.